Welcome to Learning Nebula, where medical concepts become visual and crystal clear.
Welcome, everyone. In this explainer, we're going to completely transform the way you think about a fundamental clinical skill, examining the arterial pulse. We're going to learn how to go from just, counting a heart rate to actually reading the detailed story the heart is telling us. So what exactly are we feeling when we take a pulse? You might think we're feeling blood rushing past our fingertips, but it's actually way more interesting than that. As you can see here, what we're really feeling is a pressure wave. It's this pulse of energy from the heart's contraction that travels about 10 meters per second. That's so much faster than the blood itself. And this is exactly what we're going to dig into today. By the end of this session, you'll see that every single beat is packed with information about cardiac function. And you'll have the tools to start reading that story for yourself. So here's our game plan. We'll start with the physiology, the why behind the pressure wave. Then we'll cover the how, your palpation technique. And finally, the really exciting part, interpreting what you feel and linking it directly to specific heart conditions. All right, let's dive right into our first section. To properly interpret the pulse, we've got to understand what creates it in the first place. So let's get into the why. This diagram shows the journey perfectly. It all kicks off with that powerful squeeze from the left ventricle. It pushes this big volume of blood into the aorta, and the aorta's elastic wall expands to handle it. That creates a high pressure zone, and it's that pressure wave that travels all the way down to the radial artery at your wrist. Okay, now this is where it gets really cool. The pulse isn't just one simple event. As this shows, it's actually made up of that primary forward wave from the heart, but also a second reflected wave. This wave literally bounces back from the smaller, stiffer arteries way out in the periphery. It's the combination of these two waves that creates the shape we actually feel. So here's the crucial clinical takeaway. The health of the arteries completely changes this story. In young, flexible arteries, that reflected wave comes back late, which is good. It helps coronary perfusion. But in older, stiffer arteries, that wave comes back much, much faster. It actually crashes into the primary wave, which jacks up the blood pressure and forces the heart to work a lot harder. This is a super important concept. Okay, so we've got the why down. Let's move on to the how. We have the theory, so let's get practical. How do we properly feel this complex wave? This breaks down the essentials. First off, your patient should be relaxed, with their arms supported right at heart level. And for you, consistency is everything. Use the same fingers, usually your index and middle fingers, every single time. It helps build the sensitivity you need to pick up on those really subtle changes. And this right here shows you exactly why that arm position is so critical. It's just simple gravity. If the arm's too high, the pulse is going to feel falsely weak. Too low, and it'll feel falsely strong. It's a small detail, but it can completely throw off your assessment. So always make sure that arm is level with the heart. Now that we have our technique down, let's start decoding the information the pulse is giving us. We'll start with the two most basic things, its rhythm and its strength or amplitude. The very first thing to check is the rhythm. Are the intervals between the beats nice and even? That's what you see in the regular sinus rhythm on the left. Or are they all over the place, chaotic and unpredictable, like the atrial fibrillation on the right? Feeling for that regularity, or the lack of it, is often your very first clue that there might be an arrhythmia. Next up is amplitude. That's basically the force of the pulse you feel under your fingers. It reflects the pulse pressure, the difference between systolic and diastolic blood pressure. And to keep things standardized, we use this simple 0 to 4+ scale. As you can see, a normal, healthy pulse is graded as a 2+. Now, here's a really important clinical distinction, the difference between a faint pulse and a weak one. A faint pulse is one that's hard to even find, and you can easily block it with just light pressure. That points to big problems like shock. A weak pulse, on the other hand, is there, you can feel it, but it just feels low in intensity and narrow. That suggests a whole different set of issues like heart failure or a narrowed aortic valve. Okay, now we're moving beyond the basics. We're going from rhythm and amplitude to the most diagnostically rich information of all, the actual shape or contour of the waveform itself. This is really where the art of pulse diagnosis comes in. This slide is our map of a normal pulse. And with practice, you can actually learn to feel these different parts. First, there's that quick, snappy upstroke as the ventricle contracts. Then you feel the sharp peak. And finally, there's a slower downstroke that has a little hiccup in it. That's the dicrotic notch, and it's the aortic valve snapping shut. All right, this is where it all comes together. Now that we know what a normal pulse shape feels like, let's see how changes to that shape can point us directly to a specific diagnosis. This table lays out some of the classics. An anacratic pulse feels slow to rise, with a delayed peak. That's a key sign of aortic stenosis. Pulses by spherins feels like it has two separate peaks in one beat. Pulses alternans alternates between strong and weak beats, and we'll talk more about that one in a second. And a dicrotic pulse feels like two beats when there's only one. Each has a unique feel and a strong clinical link. Let's look closer at two of these. On the left, with aortic stenosis, that valve is super narrow, making it tough for blood to get out. That resistance is what causes that slow, delayed pulse. Now look right. With aortic regurgitation, the valve is leaky. That creates a big initial gush of blood followed by a sudden drop-off, which gives you that double-peaked or bisepherence pulse. You can really see how the mechanical problem in the heart directly creates the wave we feel. Now, if you ever feel a rhythm of strong beat, weak beat, strong beat, weak beat, you need to pay very close attention. This is called pulsus alternans, and as the slide says, it is always a bad sign. It indicates severe dysfunction of the left ventricle. This is a serious finding you absolutely cannot afford to miss. So, to wrap it all up, the main takeaway is right here. Diagnosing through the pulse isn't about one magic sign. It's about a systematic approach, palpating carefully, always comparing the pulse on both sides of the body, and training your fingers to recognize these key waveforms. And that concludes our explainer on the arterial pulse. I really hope this gives you a framework to go beyond just counting the rate and to start truly reading the story that's right there at your fingertips. So the question is, what will you listen for? Thanks for joining me.
If you're aiming for a deeper understanding or preparing for your practical exams, you can explore my book for comprehensive, exam-focused learning.